Hello, everyone. Welcome to the Dr. Sophia ObGyn Podcast. I'm an ObGyn practicing for over 15 years in my native New York City, and I love to help women learn about their bodies, empower them, and embrace themselves. On this podcast, we talk openly and with heart about all things affecting women, from pregnancy, menopause, periods, sexual health, fertility, and so much more. Disclaimer: this is general medical information based on my professional opinion and experience. For specific medical advice, please refer to your physician. Hello, everyone, and welcome to the Dr. Sophia ObGyn Podcast. Today is a little different than our usual topics in that I just kind of felt like talking about a few patients that I have right now that have really been on my mind. And the thing that they all have in common is something called recurrent pregnancy loss. And I realized that part of the reason why they've been on my mind is because every single time one of these young ladies gets pregnant, it puts me on edge. And I realized that I'm on edge and I'm only their provider. And it made me think, wow, other women are probably on edge too if they have this as an experience. And I just wanted to bring it to the forefront, something that probably a lot of people don't even think about or don't know about, which is this thing called recurrent pregnancy loss. It's basically miscarriage, and I wanted to talk about it. So, of course, it started off with a conversation with you, Touseef, as all of our conversations do. And so without further ado, welcome, please, my co-host and wonderful friend, Touseef Mirza.
Hi, everybody. So I didn't even know about this term. I'm just going to be very honest. Let's start from zero. What is recurrent pregnancy loss?
So recurrent pregnancy loss is when a woman has had 2 or more miscarriages consecutively. So meaning that they get pregnant and they have a miscarriage, then they get pregnant again. Whenever that next pregnancy is, they have another miscarriage. And once they've had 2 back to back, so there's no pregnancy that actually leads to a live birth in between, there's no termination in between. They've had 2 back-to-back losses from a natural cause, like it just happens. And as the term we usually use is miscarriage for that. So once they've had 2 or more, then they fall into this category of recurrent pregnancy loss. And usually at the third one, we would then start a workup, why is this happening? Definitely after the first miscarriage. We've talked about this before, about the concept that, up to 20 to 25% of pregnancies, especially in the very first, couple of weeks of pregnancy, up to this, 6 to 8 weeks of pregnancy can end up as a miscarriage.
What's the percentage again?
About 20 to 25%.
That's
so
a lot.
1 in 4 almost can end up as a miscarriage. But a woman who gets pregnant has a loss, gets pregnant, has a loss, gets pregnant, has a loss.
At any point of a pregnancy, though, not just like within that time frame.
Usually we're talking about a pregnancy loss that happens early in pregnancy when we think about recurrent pregnancy loss.
Okay.
However, yes, we're talking about a consecutive loss that happens at any trimester, to be honest, if it's consecutive. So whether that's at 14 weeks, at 8 weeks, at 6 weeks, even at 20 weeks, then it can still all fall under the category of recurrent pregnancy loss if that loss was not of her own, her body, it just happened. And we don't know necessarily why, or we don't know why it was happening in that moment. And it's not necessarily something like if she's further along in the pregnancy that we can say, okay, this is due to premature labor, for example, or that we can identify certain other things, perhaps infection or things. So that those are things that sometimes can happen later on in pregnancy. So we don't usually consider those in that kind of scenario. And certainly once we get to the point of a pregnancy that's considered viable, then we have the potential for a live birth. After 24 weeks, let's say, let's use that as a cutoff. there's the potential for having a live birth. And so even if that live birth is with a lot of perhaps complications or et cetera, but different than when we think about a recurrent pregnancy loss, which tends to happen early and within the first trimester.
Within the first trimester. Okay. All right. And the first trimester goes up to?
Up to 14 weeks.
14 weeks.
Yeah. So 12 weeks if we're thinking from the time of conception, 14 weeks if we think from the time of the last period.
Okay. And then I believe that the longer that you are pregnant, the lower the chances
of miscarrying. Yes.
Okay.
Yes.
So it's almost like the body at the beginning, like tries to test everything out and say, okay, is this going to be a good one or not?
The growing embryo just becomes stronger and so is more resistant to loss. Whereas there's some sense of fragility early on, right? That's one. And then two, early on, we think about most recurrent pregnancy loss. Well, I shouldn't even say it like most. Honestly, 50% of them, we have absolutely no idea why, if not more.
Of why
it happens, of why a woman may have recurrent pregnancy loss. It's totally unexplained. But we do know that there are some cases where it's genetic, right? Some kind of lethal chromosomal abnormality that simply is not compatible with life. And so therefore you have a miscarriage. But if that genetic problem is recurrent in that specific egg or sperm, and it just so happens the luck of the draw is that they get another egg or sperm that happens to have that same problem or another genetic problem, for example. And so therefore that becomes constantly part of the recurrent pregnancy loss. But most of the time we just don't even know why. There's so many different issues that women have to deal with. On the one hand, it's, can I even get pregnant? So that's the women who are struggling and having infertility, like can't even get pregnant. They're doing everything right and they can't get pregnant. On this hand, you have the women who are getting pregnant, but are having a hard time staying pregnant. And they are having a hard time staying pregnant in the early part of pregnancy, where we are talking about this recurrent pregnancy loss. There are other women who can get pregnant, they get past this point, and then they have another issue in terms of staying pregnant.
After the first trimester.
After the first trimester, into their second trimester. And that's a whole nother issue. And so it was weighing on me because here it is, I have a patient I'm excited for, but I feel apprehensive because here it is, she calls me up. And in these circumstances, you tell the patient, look, the second you get your pregnancy test is positive, I want you to call.
Because they've already told you that they want to get pregnant.
That they want to be pregnant. They've already experienced this concept of recurrent pregnancy loss. This particular patient who called me today, she's had already 4 consecutive losses. And this is now the 5th time that she has been pregnant. And I'm thinking to myself, I'm the doctor. Like, this is not even happening to me. And yet I'm feeling a sense of anxiety about it. I'm feeling a sense of, oh my gosh, is this one going to stick?
You've been through the 4 previous losses?
I haven't been through all 4, but I've been through 3 of them. And it's kind of like, how are we going to make this okay? Like, is this going to be okay? Is this going to actually be the time that it's going to lead to a pregnancy that's going to go through all of the trimesters and lead to a live birth?
The question that comes to my mind is, if this has happened 3 times previously with you, I mean, while she was your patient, is there anything different that you asked her to do to try to move away for any type of risk that she might have been previously?
So here's the thing. In this particular patient, we've done all the things in terms of a workup, making sure she doesn't have any infections, making sure she doesn't have any issues with her uterus, making sure that she doesn't have something called like a thrombophilia, which is where she may be more prone to like blood clots and things like that, doesn't have a thyroid disease, doesn't have diabetes, like she's an average weight woman. So it's like there's no indicator as to why this is happening.
And she's of childbearing age?
And she's like 30 something years old, like early 30s.
Okay.
So it's like, why does this keep happening? So now I'm like, okay, we're just going to throw the book at this. But moreover, after she had the fourth one, I said to her, I feel like my hands are tied. I don't know what else to do for you. I've done the workup. I haven't come up with an answer. I actually think you'd be better suited to see someone like a reproductive endocrinologist, which is a fertility specialist. She's like, but I'm not infertile. And I said, I know. I said, I know that you're not infertile. This is not the purpose. They do more than just treating women who have infertility in the sense of they have trouble getting pregnant, but they also help to treat women who have a problem staying pregnant. And maybe there's something that they'll see that I don't see, you know,
or they have
other tests or other experience, you know, that I don't have. And she said, yes, but you're the one who's seen me through all of this. And I feel like you're the one who's the most invested. And the reality is that I really do feel invested.
I mean, you're literally saying that, you're with them for the ride.
I'm with them for the ride, but that's exactly it. It's a ride, and it's like a roller coaster that honestly, I just can't even imagine being in their shoes, because in my own shoes, I feel a sense of anxiousness
for them.
So I cannot even begin to imagine what it is for them. That level of uneasiness, anxiety, apprehension. I can't believe I'm pregnant again. Do I even want to be pregnant again? Or I want to be pregnant again. And then all of the different emotions that they must go through.
But also, if you have had 4 losses previously and you're pregnant again, I feel like you would always be walking on eggshells.
Yes.
Like you can't say, well, I can't do this, or I can't do that, or I can't do this. And rightfully so. But at the same time, it's like this weight of guilt that is just waiting to like get back at you if something goes awry.
I'm telling you, this is a subset of women whom I feel are so strong. I mean, women are strong, but to go again and again and again, and with knowing that there's a possibility of the loss, right? But that the desire for motherhood is so strong. I look at them in awe, because I think about it for myself and I say to myself, wow, would I have been able to do that? Would I have been able to go back again and again, knowing that there's a possibility that I may end up in the same place without the goal or the outcome that I'm searching for so desperately? And it just pains me, and that's why I wanted to talk about it, because I just feel like, it's a problem already. We don't talk about miscarriage, right? Women don't have a space or a place to really open up and talk about miscarriage. And then add to it the layer of those women who have had not 1, not 2, 3, 4, 5 miscarriages in a row, all in their quest to become mothers. Like I said, different from those women who keep trying and can't get pregnant, and again, don't have answers. Because this is like almost like 2 halves of one coin, because for a lot of women who deal with complete infertility, we don't even know why it's happening.
Because they can't get pregnant.
They can't get pregnant.
Right.
And then we have the subset of women who get pregnant and can't stay pregnant. Whew. So that's one. And so it seems like things happen like in threes. So I have this patient, another one now, who's had about 3 or 4 losses. And one of the things that makes her case a little bit different is that she has some mental health issues. And so it's like, okay, how do we balance the medications that she needs in order to just manage her life, like to manage her
from a mental
illness,
health
from a mental health perspective, right? To be able to manage some of her illnesses in a way that still gets her to be fully functional, feels very normal, right? But at the same time, we're not sure if any of those drugs that she needs to be on for her day to day are contributing to her history of recurrent pregnancy loss? How do we balance the drugs that she needs to be on while still understanding and managing her full desire to be a mom? And the real interesting part is that she's not on anything that would cause what we call teratogenesis. So that's when we think about drugs that are going to cause like birth defects. That's just a big word for birth defects, right?
Which are usually studied with any type of drugs.
Which are studied typically. And, you know, we have these different classes of drugs. And so we can usually say, okay, well, what's the risk benefit here? And in her case, none of the drugs that she's on actually cause quote unquote birth defects, but we also don't know what role they may be playing in her situation of recurrent pregnancy loss.
So you're saying that the birth defects is really talking about once the fetus is developing versus in this situation, it hasn't even arrived at that point yet because we've had a miscarriage.
Well, that's one, but two, that these are drugs that have actually been studied and they do not cause quote unquote birth defects, right? Like they should be safe under the conditions that we would typically take them, that it should be safe even if a woman got pregnant while on the drug. The problem is the correlation between pregnancy loss may not have been studied. And so yes, versus birth defects, like is the baby going to be born with a problem with its heart or its brain, or you get what I'm saying? And so we may have data that says, okay, there's no birth defects, but then we don't necessarily have data that says there's no problem in terms of recurrent pregnancy loss. And so we're at a crossroads because here she is, she comes to me, she's pregnant and she's already anxious. She already suffers from a baseline level of anxiety for which she needs to be treated. And here I am saying, okay, I think you may need to come off of your anxiety medication. I think you may need to come off of the medication that helps you to function as a person on an everyday basis if we're trying to keep you pregnant.
Because that might or might not
be
a cause. So you're playing detective at this point because you're just like, what has changed from the previous time that you were pregnant? Okay, nothing, but we do know that you were on the same meds as before.
Every time.
Right. So therefore, maybe the way to do it is to remove that because there's no studies around it. So there might be or not a correlation. But at this point, the woman really wants to get pregnant again or wants to keep her pregnancy.
Exactly.
And you just have to try everything that you can.
Right. But then we're talking about women who are in their prime and they're dynamic and they're in their professions and they're trying to show up every day and still go through the reproductive part of their life and the desire that they have to be mothers. So to be like, well, I think you need to reconsider these medications. I think you need to come off of them. And then but then how am I supposed to do my job? How am I supposed to show up in the world? How do I manage this, either the anxiety or the depression or the ADHD or whatever that mental health illness is? What's so hard is that when we think about mental health, we think about it different than we do like just diabetes, or we think about it different than we think about like high blood pressure. You know, it's kind of like, oh, just come off of it. You'll be fine. Just go to your therapist. And it's not that simple because for a lot of people, those are the drugs that help them to stay functional at their highest capacity, right? That makes them feel they're the most themselves. That helps them get through their day-to-day challenges. So it's not so easy to just be like, just come off of it, or I'm just going to change you to something else that may not be as effective, you know, in managing the illness. Whereas we have so many different options when it comes to perhaps blood pressure or asthma or diabetes. But when it comes to our mental health drugs, we're very limited. And then so to then say, well, I have to take you off of even the ones that we consider as safe. it's like, I don't know, my hands are tied.
So therefore, what is needed then? Is it more studies around understanding what can potentially cause recurrent pregnancy loss, and or we just need more development of different types of solutions around this area altogether?
I mean, I wish I had the answer. I think my whole purpose here is to simply put it out there that it's a challenge. It's a challenge for the patients and it's a challenge for the providers. And I just don't want women suffering in silence. We'll see our friends, maybe they've been married, 5 or 6 years, and you go to that person and you say, "Oh my gosh, I can't believe you guys haven't had a baby yet." Not knowing that she's had 4 losses, right? Because that part hasn't been shared. And I guess the point here is to just be a little bit more sensitive, empathetic, not rush to have questions
Or conclusions.
And I did say that this came in threes. And here's the third final story that I wanted to talk about, because this one has had 3 losses back to back. Here it is, her 4th pregnancy. Here it is, she's now made it to 9 weeks. We never made it this far.
This is a milestone.
This is a milestone. So she does have some type of an autoimmune disease, but it's not the ones that we're like, okay, we know for sure, like lupus or something where we can say, okay, we know what you need is to just be on anticoagulation throughout this pregnancy, and this is going to be okay. I mean, at this point, I was like, okay, let's go. We're going to do everything. We're going to try an anticoagulant. We're going to try some progesterone supplementation. When she had the losses, I was like, okay, well, what are you eating? How are you eating? What are you doing? Are you exercising?
Are you stressed?
Are you stressed? How can we manage your stress? But getting to that marker, now you start to set these like little goals. They're mini goals, because it's almost like every single week that you're still pregnant is like,
like, okay, we did this part.
We got here. And so she continues on with the pregnancy, and she makes it now to about 20 weeks. And we're both like, oh my God, okay. And now I'm like, okay, the likelihood that she's going to have a miscarriage is very unlikely now, right?
Because we passed the first
We've passed the first trimester. We're way past the first trimester. She's on her anticoagulation. She's on, her vitamins and all the things in that sense, right? Okay. Now we get to 21 weeks. She's getting her sonogram. Her cervix is short. And I'm like, wait, what?
What does that mean?
We just got through the phase of like being excited that we're not in the zone of miscarriage anymore. And now we're back in it, because her cervix, which is supposed to be, let's say, I like to give people the example. Okay, imagine I need your cervix to be 4 knuckles.
Okay.
So the length of 4 knuckles. Okay. And when we're in labor, what happens is our fist, that's our cervix, the knuckles need to kind of become thinner and thinner. So this is what it means to be thinner. And then it just like each knuckle kind of like melts away. And then your cervix also needs to open.
So this is right at the bottom of the uterus.
This is the bottom of the uterus in terms of what happens when you actually give birth.
So it's like elastic. That's what you're trying to say?
It's not even that it's elastic. Part of the process for one to give birth is that the cervix needs to both shorten and open.
Okay.
But we don't want that process to happen until they're like 39 weeks.
Okay.
Here we are at 21 weeks, and her cervix is like, let's say it's only one little finger. It's all of this is gone. She's just, this is it. We've only got 1 centimeter when it should be 4. And I'm like, now what? Well, now what is we got to figure out how to keep it closed. We've got to figure out how to get some extra length from it.
What happens if it stays short? What is the
risk, the
risk?
problem here, yes. Thanks for asking the question. The problem is that if she has a short cervix, we're only 21 weeks, her risk of having a premature delivery is extremely high. And at 21 weeks, we're not even at the point of viability yet. We're not at the point where this baby can survive outside of the womb. So if she has a baby at that time, then that's a miscarriage.
Because it can't live after. It can't be a premature baby at that point.
No.
How many weeks is it considered not a miscarriage anymore, but a premature baby?
And maybe I misspoke when I said miscarriage, because at this point she would give birth, perhaps at 21 weeks. If she did, she'd give birth. And because it could be a live fetus, but it wouldn't be one that would survive.
Okay.
So I'm like, no, this can't be what's happening right now. And then to have to go back to explain to her that this is what's happening, because she's not feeling anything.
Mm-hmm.
She was fine. She's like, whoa, what's going on? Your face has changed, because now I can't hide that.
Mm-hmm.
And it's not something to hide. It's just now I have to figure out how to explain what's happening and what's the next step. What are we going to do about it? I mean, I feel stressed now. just remembering, And so at that point, we offered her to get back on progesterone, a therapy that we had started for her in the earlier part of the pregnancy, again, as part of the how to help keep her pregnant with the recurrent pregnancy loss situation. Then around 10, 11 weeks, 12 weeks, we take her off of progesterone because now her body is able to supplement and do all the progesterone that her body needs for the rest of the pregnancy, which it did. Here we are, we're 21 weeks. She's fine in terms of a live fetus, but then now her cervix has the problem. So we put her back on progesterone, which is to help with the cervix. And we also do a procedure called a cerclage. Cerclage, I kind of like this term. I like this word because it's like circle, cerclage.
Sounds French.
It feels very much of what it is.
Okay.
And it's where you put a stitch around in a circle around the cervix in order to hopefully cinch it closed and to keep it closed.
And so the reason why you don't want the cervix to be in the situation that this patient was in is because maybe the fetus would literally come out?
Yes.
So it can't stay in the uterus.
Yeah. The cervix could literally open without her knowing.
It's like everything has to work perfectly inside. All these different things.
Every time, us being here
is a miracle.
Is a miracle. Every birth. I say it all the time that we are a miracle. And imagine the real miracle babies out here. This baby, thank God, that's still inside. She's still pregnant and we're still counting and still getting to each goal. That for me, it's okay. We made it to 21 weeks. We did the thing. We put the cerclage. She's on her progesterone right now. And every 2 weeks we're monitoring, is the cervix still closed? Is the cervix still holding? And the next step was to get to 24 weeks. And we were like, hallelujah, we made it to 24 weeks. Why? Because 24 weeks is, she could go to an institution where at 24 weeks, this baby can survive outside of the womb.
And by putting them in an incubator.
In an incubator to continue to grow. But the likelihood is that baby would survive. At 24 weeks.
Even if she's
C-section, or even if she had a birth, whichever way she birthed that baby, there's a high success rate that this baby will, after it's born, that we would have medical intervention that could keep that baby alive.
So 24 weeks
was another milestone.
It's a huge milestone.
It's a huge milestone. Then we get from 24 weeks. Now we need to get to 28 weeks, another milestone. But in this case, it's like every week that we gain is a milestone. So every single time I see her, I speak to her, I'm like, are you okay? How's it going? And at the same time, the reason why I bring up this particular case is because she has this history of recurrent pregnancy loss. I now tell her She's been going through the pregnancy. We've been so happy. And now I'm like, I need you to be on complete bed rest. I need you to not go out and be who you are in the world anymore as of today, and just grow your baby.
This is like around 26 weeks.
No. This is at 21 weeks.
Oh, this is at 21 weeks. Okay. I understand, because now there's literally just a few weeks left until you reach that milestone of 24 weeks.
I want her to get to the end of the pregnancy, which is 40 weeks. Let's be clear.
Yes, of course, yes.
Right?
Yeah.
But I'm still trying to just get to certain milestones. But to be going along all fine, you're fine, right? You're still going to work. You're still intimate with your partner. You're still, being who you are. And now I've told you, stop everything. The only thing you are allowed to do right now is grow your baby. It's like putting a woman into prison. Because now I've shut you off from the rest of the world except for your doctor's appointments. And having to deal with the mental anguish of that now. So she already had to go through the mental anguish and anxiousness, etc., of having had all these losses. Now she finally gets pregnant, and she's very happy about the pregnancy, and we are very happy about the pregnancy, and it looks like things are on the up and up. Everything is okay. And then we get to the halfway mark, and boom, we're hit with another thing, which is now that the cervix is short. And it's so short that I don't think that it's a good idea for her to work. I don't think it's a good idea for her to do anything. I just want her to go home and grow her baby. But I can't just say that. I mean, we talk about it, but where are we also talking about the impact of pulling someone out of work? What is the financial impact of that? What is the mental impact of that? The emotional impact of that? And in her case, her best friend's wedding was coming up. Unfortunately, she had a cousin who passed away. And her inability to participate in things that she would be in, right? Because now I've said, I want you resting at all times. If anything, I only want you doing the minimum that you need to do to care for yourself. And that's it. Right? Because I don't want it. Just imagine the cervix as being like a dam, and we got to keep it closed, even in the storm. We've got to keep it closed. And we want to get to the point where your baby is so well developed that we know that your baby's going to be okay. And really, that's not until, in all honesty, I want to get a baby as far as 37 weeks when we normally deliver a baby. Like I would say the average, right? 40 weeks. That's your due date. But it's like every step of the way is like, okay, we got to 24 weeks. Okay, we're get to 26 weeks. Okay, we just got to get to 28 weeks and so forth.
And you have to keep assessing every single time.
And every single time we're assessing.
To see like, okay, do we need bed rest, or is it okay? Or how's it evolving?
No. This bed rest is until we have this baby.
Okay. That is just what needs to happen no matter what.
Yeah. Until
because
we get to
cervix.
36 weeks, then I can be like, okay, maybe now. Because now at 36 weeks, at least, for example, that cerclage, that stitch that I put in, I would take out because the anticipation is, okay, after this point, your body may naturally want to go into labor, which is the normal process. And so I don't want to have this thing holding it up. Now I actually want to take that out, right? So up to 36 weeks, I want her just growing her baby. I really bring this up because I recognize the difficulty with which women have to deal with this particular issue of whether it's the recurrent pregnancy loss. And in this particular case, she's overcome that part and then have another setback within the pregnancy. A pregnancy every single time is its own little miracle, basically. And the main point is to recognize that women we just don't share enough. This is a topic that I don't think anybody really talks about. And I don't even bring it up because I have answers.
That's what I was going to say. Like this episode, as opposed to other episodes, we educate, obviously, but then we provide solutions. But this one is to acknowledge that there is a gray zone, to acknowledge that it's not something that automatically a provider is going to know what to do, but they have to make assessments, and then they have to look how things are evolving and then fine tune in accordance and then continue.
Yes. And in this particular case, you're working as a team. I had to work with my high risk doctor, and I have to work with my geneticist. And then, there are all these other things you have to do with these patients in terms of sending them to different specialists in order to achieve the goal, which is a live birth. And I actually just want to applaud the women who've had to deal with this, to let them know that they're not alone, that this is actually, it's not super common, but it's common enough. I mean, about maybe 5% of women have experienced recurrent pregnancy loss, and that's just having 2 consecutive losses. And then maybe about 1% of women of reproductive age have had 3 consecutive losses. But that's not a small number. It seems small when we're talking about it in terms of percentages, but I'm telling you about these 3 just in the last few weeks of me just work, my regular work. Mm-hmm. And I've seen this multiple times. It's not just this is the first time. It's just because I had this little conglomerate that just happened all together that made me want to talk about it, because I see what it has done to the patients, how these women still remain resilient.
That was the word I was going to say. I mean, I'm amazed that women going through this even just 1 time, and then 2 times, and then 3 times, and they still want to get pregnant. I mean, that level of resilience and determination,
yes,
is spectacular. Like, I don't even understand that. Really, like that, to go through that emotional roller coaster, the physical aspects.
Yes.
Every time you have to get all these tests and figure out, and
yes,
and then it doesn't work, and you say, okay,
back to the drawing board.
We're going to try again. We're going to try again.
Yes.
I'm going to try again.
Yes. Oh, I love taking care of women because we're pretty incredible.
Mm. Mm-hmm. So sending love to all these resilient, amazing, beautiful women.
Yes, that's exactly what I'm doing. That's exactly what we are here for, what we are doing. To all of the women who are experiencing miscarriage, recurrent pregnancy loss, this is an episode just for you, so that you know you're not alone, and that you can continue to embrace your body and embrace yourself. Thank you for joining us on the Dr. Sophia ObGyn Podcast. See you later.
Bye.
This is general medical information based on my professional opinion and experience. For specific medical advice, please refer to your physician. Until next time, embrace your body, embrace yourself.